My name is Dr. Tim Brown, and I will be talking to you today about insomnia management and the pitfalls associated with the drugs. As you can see from my bio, I am the Director of Interprofessional Education for the University of Georgia's College of Pharmacy and also a professor at Augusta University UGA's Partnership in Athens, Georgia. I have no disclosures to make here with regard to the medications in our discussion today. The objectives of the talk that we're going to be looking at really deal with the diagnostic criteria of insomnia. We're also going to talk about the medications in general, but I really want to talk about their pitfalls and what the evidence-based medicine is showing us about their use. Spend a bit of time on non-pharmacologic approaches because it is the backbone or the mainstay of management. Then also talk a bit about treatment goals, patient education, and what we look at clinically with regard to insomnia. Insomnia is one of the most common complaints you hear in a medical office. It is widely apparent that in the last year, stress has increased even more so, and so insomnia has become almost a daily occurrence with regard to people talking about lack of sleep, stress, and worry. It's very prevalent in women, and as we age, it also becomes more apparent. In addition to that, they see it much more with psychiatric illness. About 50% of the cases discussed with insomnia usually are associated with some background in dealing with psychiatry or mental health. Also, it can have a role when it deals with societal stressors, such as poverty, dealing with losing a job, or working and worrying about how ends are going to meet when it comes to finances and life in general. Symptoms may wax and wane. I think it's important to realize that insomnia may not happen all at once. In other words, it may not be persistent for 6 months. It may come in spurts, quite frankly, based on what's causing it and what's going on. So it's not that it has to occur necessarily for a given period of time, but we'll talk about the definition in just a moment of what persistent insomnia looks like. Please realize that when you're looking at patients and what's going on, that 1 in 5 have discussed using some sort of medication to help them sleep in the evening, about 20%. It's a large number when you stop and think about it. So it's important that you look at the background of the patient and who you're dealing with and what's going on when it comes to insomnia, because it could be a symptom of what's happening in their lives at the time. Now, I mentioned insomnia as a symptom. Honestly, that's probably not fair. Insomnia can exist all on its own. It does not have to have a mental health background or a stressor going on. You simply could have insomnia. So it's important that we treat each patient individually and not group them into one area. But it is important that we know how to define insomnia. And so when you look at the DSM-5, it really talks about the quantity and quality of sleep. And there's 3 aspects to insomnia. First is difficulty falling asleep or initiating. The second is maintaining or staying asleep through the evening. And the third is wakening in the early morning hours, so not getting a full night's rest even though you know you should or your body is telling you to. If this occurs greater than 3 nights per week and is present for about 3 months or 90 days, it is considered to be persistent insomnia. So as I mentioned earlier, this might happen during a time of the year where things are particularly stressful. Think about folks that have maybe lost a loved one in the past, and as the anniversary of that date comes around, the holidays may be a great example. And for others, it may be a change. So when we talk about seasonal change, children going back to school, those kinds of aspects. So once again, it can wax and wane with the symptoms. Please keep in mind that insomnia can occur, as I've mentioned, without it being due to something. But one of the areas I really want to address in a moment is the things that can actually precipitate or cause insomnia. When you look at the different disease states that are out there, many of them can impact and cause insomnia. Because of that, I want you really to take a look at the boxes and note some of the areas that you should rule out. One of the bigger ones that we talk a great deal about is obstructive sleep apnea, OSA. Is this playing a significant role here? What's the body habitus of your patient? If you can usually use a CPAP or BiPAP, you may take care of the insomnia by taking care of the OSA. That's an example of knowing the underlying cause that could actually take a significant problem the patient's undergoing and get rid of it by taking care of 2 situations at one time with one remedy. Substance abuse withdrawal. Again, over the past year, we've seen a large number of people drinking more and possibly even using narcotics and other medicines to a higher degree. If they're trying to withdraw as things are sort of normalizing in their life, they're going to work now and leaving the house 5 days a week, then you may see issues with sleep there. Also, please keep in mind anything dealing with incontinence, having to urinate frequently over the evening can cause people to be up all times of the night and not maintaining their sleep. Then Other things you'd look for: blood sugars, thyroid, doing lab testing. So it's important that you sort of go through a checkbox and get a really great history of what the patient's going through, either past medical or current situations that are happening. So, first question of the day: what is the first step in the management of insomnia disorder? A, recommend an OTC sedating antihistamine. B, prescribe trazodone. C, perform a medication review. D, recommend increasing exercise. Or E, prescribing a low-dose non-benzodiazepine receptor agonist. I'll give you a moment to answer that question. In this situation, you really want to look at a medication review first. The reason for this is medications in general should not be given for insomnia until non-pharmacologic avenues have been taken before. So looking at A, B, and E, those would not be a great choice here. You'd want to hold off on medications. D, increasing exercise, if you do it near bedtime, is actually not a great answer. What you want to do is look at a medication review first. As we talked about with disease state management, if you can look at the medications, there's a possibility there could be an underlying problem with what they're taking. If you look at the boxes here, you'll see there's a host of different drugs that can play a role with sleep disorder. Don't forget looking at herbals and OTCs as well. When you're doing a medication review or medication history, it's not just the prescription drugs. Someone could be using, for example, bitter orange. You also have to delve a bit into their personal use of illicit products. If they're using stimulants, if they're using anything like cocaine, then you could have a problem when it comes to sleep as well. Obviously, the problem is deeper than sleep when you talk about illicit substances, but at least we give you an idea of where the sleep pattern disturbance is coming from. Also note other aspects that are kind of commonplace, for example, corticosteroids, even albuterol use. How often are they using their rescue inhaler? And then please keep in mind that anytime you deal with over-the-counter medications, for example, decongestants, they can have a stimulating effect as well. So talking to your patient. If you have a patient who's discussing insomnia and what should they do, and you're trying to counsel them through it, and medications have been decided to be an option for this particular patient, here are some ideas or thoughts you should be having in your mind as a pharmacist to talk with your patients. Make sure they're taking the medications close to bedtime, and only if they have can able to devote a full night's sleep. In other words, that's 7 to 8 hours. Otherwise, the residual effects may happen if they're waking up earlier or have to be up earlier because of commitments. One of the key things is next day impairment. Please have them take this medication where the next day they can have an idea of how much it impacted them, but did not impact what they were doing with their routine. So, for example, if they have Saturday and Sunday off, maybe taking their first dose on a Friday night so they can see how it really impacts them for the weekend, not necessarily on one of the days where they have a lot of responsibilities and they have to be up for it. Also, let them know that this is a common occurrence and they should be looking out for it because driving, taking care of children, or making any kind of big decisions could be impacted by the medication they took the night before. Taking these with meals or immediately after meals sometimes can slow their absorption, so that may not be the best thing to do to get the full impact of the dose. And they should not be used with alcohol or other CNS depressants, including, of course, narcotics or opioids. They can develop tolerance or dependence and require more to help them sleep each night. If this is occurring, they need to speak with someone about this immediately. Self-escalation of dosing is not where this needs to go. As a matter of fact, we should be doing a de-escalation of dosing if we talk about the fact that the medication should be ending in 4 to 5 weeks. Also, please keep in mind I've talked about the complex aspects when it comes to neuropsychiatry, the overeating or the getting up in the middle of the night to eat, driving, not realizing that you've driven somewhere, walking outside your home almost as though you're sleepwalking. So please keep in mind that people need to hear this, know this, and be in a safe environment with someone around them when they take these medications. That way they have someone to watch over them, so if these side effects do occur, they can be noted and found by a family member or a close member on especially the first few nights that they're using the medication. Then we've also talked about hypersensitivity reactions overall in dealing with anaphylaxis. I hope you've enjoyed this discussion today on insomnia. I hope we've talked about the literature and brought some things to light. But I also hope you have a broader understanding of how to manage patients with insomnia, that it's not a simple, let's give a medication and that will take care of everything. Thank you once again. My name is Dr. Tim Brown, and I appreciate you listening to this.